So how do you do the Stiles Screen for interpretation of area grace restriction, somatic dysfunction, also we can call key lesion or key hindrance? Then you start with the screening in the standing position, and what you want, hand placement is very important. So what you want is hand placement so your thumb sits across the spine of the scapula. You want your first finger on top of the clavicle, so you're getting information of all the muscles on top of the clavicle, first rib. You want your middle finger below the clavicle. Your ring finger is gonna drape kind of down over a pec minor, and your pinky finger is gonna be across the AC joint. So in this position, bilaterally, you want to start here. You have complete control of the patient. And then you want to use blending palpation to lightly just blend into the tissues. And when you do that, because Dr. Johannes Meyer says you want to feel everything everywhere all at once. So we're just blending in bilaterally and translating just a little bit back and forth, as you can see here. And right there, there's a fascial drag that pulls down that we talked about in the blending palpation. And when you have that feeling, you know you have the patient's calcaneus grounded to the floor. So the patient has stability. Now you can check that, because if we just put our hands on and we blend in, there's a lot of mobility that goes on in the spine. But if you blend in till you get that fascial drag right there, I don't know if you can see that on the video, but you can even see how the whole back and pelvis shifts. You can jump on the shoulder and it will not budge because the patient is grounded to the floor. So that's very important. So the amount of blending in that you have to get that grounding, you just want to maintain that with your touch. So then the first thing we're going to do, and this is very important, is you want to make sure that you come and you start right at the C7, T1 junction. Commonly people come and they start right here and they miss this section. So make sure that you come and so that you're at this junction. So what you want to do is you're going to translate back and forth just to make sure you've maintained that grounding. Again, you can always check yourself, because if you give a little spring and the patient's not moving, then you know you have them grounded to the floor, so you can maximize the movement that's going to be right at the area of the spine without the patient moving all around, because if they're doing this, your hands are picking up information coming from everywhere else and you won't be able to localize it. So when we do that, I'm right-handed, so I tend to start on the patient's left side. Doesn't matter which side, because we're going to do it both sides. So you start right in here. So the first thing you're going to do is you've maintained just a little bit of blending pressure to keep your patient grounded, as you want to induce side bending. So you want to side bend just till you feel the motion underneath your hypothenar eminence here. Because if I'm here, I'm all the way down here. I'm not feeling what's going on here. So it's just enough side bending, so it's not very much. You feel the motion going on right underneath here. Side bending has to come first, and I have another little demonstration to show you so that you can see why that's so important. So you always want to do major to minor motion. So side bending comes first, just to the amount of motion it takes to feel right underneath your thumb. Then you're going to induce some rotation, but as you induce rotation, you want to do about a 60-degree glide of translation this way. So that one, you're keeping the patient's center of gravity. So they're still grounded, they're supported. You can hold on to that patient with one finger and then not feel like they're going to fall. Because if you side bend and rotate over here, there's guarding and muscle tension going on through here, because the body is like, what are you doing to me? You're going to make me fall. So come back, just enough side bending till you feel the motion right in here. 60-degree glide of translation. So it's like a dance. So everyone talks about that, like when I move, I become like a secondary body to the patient, so that my body does that motion. So I become like a long vector, a fulcrum. So you ground, blend in, just till you feel the motion there. And then you're going to feel, it should feel like a nice smooth, if things are moving as they should, it will be a nice smooth glide. There won't be any catches. Oh, and then you're going to come back to neutral. So what we're looking for is tissue texture changes. I often call them a speed bump, an area that doesn't have a smooth glide to it. Like it's a rocky point that you're hitting that's not moving, that tells you there's something going on in that area. So then you're going to slide down to your next segment. Same thing, you're going to side bend just till you feel the motion right in here. So it's a little more side bending. Then induce your translation and rotation at the same time. Again, moving pretty good. Come back, you're going to slide on down right here. There's a little hiccup here. It doesn't have that smooth glide. For demonstration, smooth. So we know there's a little something going on here, and you're just taking in all the information of where you're finding all your different dysfunctions. Starting to get some movement here. Again, you see you have to induce some more side bending, rotation, and translation as you go down. The other key point is don't stop in the lumbar. You have to spring all the way down over the lumbosacral junction. And that will be important for the next part when we're interpreting what we're feeling. So on this side, everything moves pretty good, except right in here was a little hindrance there, a little speed bump of area that did not have smooth glide. So I'm just keeping that in my head and remembering where I'm feeling things. So then I'm going to come to the other side. Now I try to not take my hands off the patient, because once I've established this good rapport of tissues and that blending palpation, this patient's tissues are open to the touch. If I take my hands off and I come back, I have to reestablish blending to get the softening of the tissues, because if I just put my hand on, there's guarding. But if you come in and you blend in, the tissues soften down. Because it's like in the blending palpation video, so it's like you come and it's a friend that's knocked on the door and you see who it is and they're like, oh, come on in. Versus when you just put your hands on the patient, that's a stranger knocking at the door that you don't know who they are, so you're hesitant about whether you're going to let them come in. So it's the unwritten communication that we have with our patients through the tissues. So I just come and slide my hand over, and then so I've maintained contact, then I can easily blend in to make sure that I'm blended and have my patient grounded. Same thing, come make sure you're over that cervical thoracic junction. Again, you're going to induce side bending just to the point that you're feeling the motion underneath where your hypothenar eminence is. Then add a little translation and rotation at the same time. So that one, you're keeping the patient center of gravity here, but you're maximizing where you're blending. And the important thing is, while we're doing this, what I didn't say is you got to be in the articular column. You got to be right in the articular column where those facets sit, because that's where the maximal motion of what we're feeling as segmental dysfunction is going to happen. We're not out at transverse process. We're not in paraspinals. We're right in the articular column of the spine. Okay, then come back, you're going to slide down to your next segment. Oh, we've got a really big speed bump area right here. As you can see, I'm trying to spring and glide. There's not very much movement there right there at all. So I know there's something going on here, and we know there's something going on here. We're going to continue on in our spring. Again, you go back to neutral, side bend, rotate, translate again. We're starting to get some movement in here, so that's moving good. And you go down each segment just till you feel the motion at your hand. Really good motion down into the lumbar segment, and make sure you go all the way down over the lumbosacral segment. Okay, once you've done that, then you've got to screen the cervical area. I like to do this first because that allows, one, the patient feels comfortable. You're not getting up into the neck area, and you've already got all this information because we know the neck is the major compensator. So then I still maintain contact, and I just slide my hand up so that we maintain that friendly touch to the patient. And you want to get, let's have you turn just a little bit this way. You're going to slide your hand up. Again, we're staying in the articular column, and we're going to drop till you feel the occiput at the top of your thumb and just kind of slide down just a little bit, because we're going to be in this upper cervical segment. Your other hand's going to go on top of the head. So what you're going to want to do is, in this case, instead of maintaining neutral, we want to just gently flex forward. And by flexing, I don't mean induce flexion. I mean, think of it as you're just starting to open the space. So what I'll say is think of this is your OA and your AAA. You want to induce just enough flexion that you've got mobility going in there, but you've not changed the full mechanics. So you're still in a relative neutral, but you've opened up the pliability of the tissues a little bit in that segment. So articular column, easiest thing is kind of just slide down off the base, so you're in the upper cervical. Induce just the least bit of flexion forward, and you will feel the softening of the tissues underneath your thumb. Same thing, you're going to add some side bending and a little rotation and translation, and you're going to feel what the tissues are doing here. Now on the upper cervical, you're feeling for, does it feel tight and leathery, or is it a speed bump, or are you feeling the muscles grabbing? Then you're going to slide down, so the cervical area you can get in 2 motions. Upper cervical, slide down, you can get the rest, the same thing. You're going to just the least bit of flexion to open up the space in there, then a little bit of side bending and rotation, and there should be smooth glute flow going. If there's not, then that tells you there's restriction. And then do the same thing on the other side. Flex the head forward just a little bit. Then do your side bending and a little translation and rotation. It's not very much. We're not doing this, because if we're doing this, then we've got all the muscles down in here activating. You're only wanting to activate in this articular column where you're feeling. So it's very localized. Things are moving pretty good here. It's very common that when you feel the neck, that everything just feels super tight and diffuse, because the cervical area is a big compensator for everything in the body. So if it's feeling really diffuse, then that's telling you that that's probably a compensatory problem that's going on and not a true individual speed bump somatic dysfunction at this point in the screen. So always do a standing and a seated screen if possible, because you're getting a lot of information, because screening in the standing position, the legs are in the equation. So we're seeing how are the legs helping the body adapt. Now we're going to screen from the seated position. So in this, feet do not have to be on the floor. Ideally, if you have a mechanical table, you want to make it for the height that's right for you so that you feel comfortable. Same thing as what we did with standing. We want to come get that same hand position. I like to start bilaterally because I'm already gathering a lot of information within the shoulder girdle. Just what does the tissue textures feel like? Does one side feel tighter than the other? So then I can gently come in, same thing, our blending palpation, blend into the tissues, and then I can translate back and forth just a little bit. As you can see, it's very subtle, but right there, there's a fascial drag that goes down, and I just loaded the ischial tuberosities to the table. So I have grounded my patient to the table so that they have stability. Because if you're not stable and I try to move, everything's moving around. But if we blend and we ground our patient, and then I go, then we know we're grounded because I could jump on the shoulder and it's not going to move because everything is loaded to those ischial tuberosities. So whatever force it took to get that fascial drag, you just want to maintain that with your driving hand here. And same thing as before, you're going to start, and it doesn't matter which side, we're screening both sides. So you want to start at that cervical thoracic junction. You want to induce a little side bending, and then you want to do your rotation and your translation at the same time, just till you're at the segment that you're palpating right in here. And it should have a nice smooth glide. And there's a smooth glide up here, but there's a little bit right in here that it's catching. It's not moving as smoothly. And then you want to come on down to the next segment. Same thing, side bend, add your rotation and your translation in about a 60-degree angle. Should have a nice smooth glide. We're doing pretty good there. Same thing. So each time you're bringing the body back to that neutral state, but you're maintaining the grounding you have on your patient. And again, side bend, then you rotate and translate just till you're at the segment that you're palpating. Is if we're down here, we're already down here and we're not where we need to be. So side bend, rotate, translate, come back, You're doing this all the way. Now, in the seated position, the lumbar was moving good standing. Sitting, I've got a big area of motion here that's locked up. So, and then come right here. It starts to move again. Again, make sure you go all the way over that lumbosacral junction. And we're going to come to the other side. Same thing, hand position. So not only are you feeling all the information here, you have complete control. This patient feels supported because you have complete control of the shoulder girdle. They're supported because you have blending palpation and you have them grounded to the table. So any motion that you induce in them, they're not gonna feel like you're gonna push them over or they have to guard because they might fall forward or backwards. So again, make sure that we're grounded. We can easily check by giving a little spring. But even without the spring, as soon as you hit that point, you're gonna feel a fascial drag down, and it's very subtle. Once you feel it, it's there and you'll know it. Same thing, cervical thoracic junction, side bend just to the amount that your motion's underneath your hypothenar eminence there, your thenar eminence. Okay, then add your translation and about a 60-degree glide. Again, we're doing this dance. So it's side bend and then your rotation and translation at the same time. Because by doing that, we're following the flow of the tensegrity of the body and we're allowing maximum mobility within the facets. And again, we're staying in that articular column. We're not in transverse processes. We're not in paraspinal muscles. We're right in the articular column where the facets sit. So coming down, sitting, we got a little speed bump here. As you can see, there's not a smooth glide. There's a hiccup there. So we know there's something going on there. And again, we're coming on down, starts to move again. And I usually stand in this position so that my body's comfortable. I'm standing back this way a little bit so that you can really see the visualization, because if you're not comfortable, your patient can't be comfortable because your forces of uncomfortableness will transfer through to the patient. So always make sure that you're feeling comfortable as well. Okay, again, coming in, side bend, then translate and rotate all the way down. There's a little bit of hold up here, but there's still some pretty good spring, and coming down over the lumbosacral junction. Same thing, come up. Next thing is we got to check the cervical area. Same thing as with standing. We're going to induce just the least bit of flexion. Again, we're just opening up this space a little bit, but maintaining a pretty relative neutral. Add a little side bending and a little rotation to translate in over the upper cervicals. Just see how that movement is. Slide your thumb down so you can get to the lower cervicals, and same thing. See if there's a nice smooth glide, and there is there. Okay, come to the other side. You're going to do the exact same thing. Induce just the least bit of flexion to open up the space. Side bend and rotate. There's a little hold up right here in the seated position that was not there with standing. And come on down into the lower cervical. So then, once we've done our screen, all the way along the way, we've paid attention to where all those areas of little hiccups were, speed bumps, tissue texture changes, hard infills, because our next step is going to be to determine where we need to start. So with screening, the importance, I say, always do major to minor motions. So you're always going to translate anterior and posteriorly till you're at the segment you are. But in the case of screening, you want to make sure that you translate till you have the patient grounded, because we're maintaining a neutral. Then you want to side bend before you rotate, because if you rotate first, and you can see this, if I rotate then try to side bend, like I just hit a brick wall and nothing wants to move at all. So by default, what happens is we put more of our force in, because we're trying to blend through the wall that we've created. So in essence, by rotating first and then trying to side bend, we end up kind of creating a type 1 lock. So the tissues all come in to respond and tighten up. But if you side bend first and induce your rotation and your translation, you can blend right into that articular column over those facets and get good motion. So in our little spine tensegrity model that we have here, I think this does a really good depiction of why the side bending before your rotation and translation is very important. because regardless of whether you're neutral, flexed, or extended, if I rotate and then try to side bend, I hit a lock. And you can even see that the adaptation in the system, it's not very much there. If you feel with your hands, you really can feel the tension in the system. And since our bodies are a tensegrity system and a tensegrity within a tensegrity, if I side bend first and then induce my rotation, the whole system can adapt and pliable. All the tension rods are soft. There is easily pliability. So the same thing applies with the screen. So if I rotate and then try to side bend, I have to work really hard to get in to feel that articular column, because the whole system is saying, what are you doing to me? And this is not, almost like it's not physiologic, so it's going to put a roadblock up. But if you side bend just to the segment that you want, and then induce your rotation and translation, everything will move smoothly. So this is the reason why I say you have to do the side bending before the rotation. And the number one thing that causes frustration with the Stiles screen is that people rotate before they translate, and then they hit a roadblock, and by default of hitting that roadblock by rotating first before side is we push hard because we can't feel anything because it tightens things up. So it's like it's really hard to feel a specific localized area when everything is diffusely tight. So this is the first step in utilizing the Stiles screen for your treatment. Again, it's important to do standing and seated just to gather information to how the legs may adapt to the body, and that will become important for when you're doing your interpretation. But if the patient can't stand, you can totally do it seated, and you're still going to follow the same pattern and model of movement to determine where we're going to go next.